My hope here is that I speak for all Californians when I extend my deepest respect and appreciation to the California Medical Board and the California Pharmaceutical Board for all their work and efforts to improve patient care. Without precedence, the California Medical Board, in conjunction with the California Board of Pharmacy, hosted a joint forum in an effort to address prescription and dispensing issues, especially as they pertain to our current prescription overdose epidemic. I attended this forum, and the following are my suggestions and questions with their attendant responses. The entire video of this forum can be found on YouTube.
Break is over. Our next panel contains a wealth of expertise and experience. To keep us on schedule, I'd like to introduce our moderator, Dr. Ron Winder, and let him introduce our panel members. Dr. Winder.
Question here, and then I'm going to come back to the gentleman on this side because I want to ask the pharmacist a couple questions. Go ahead, ask your question. Just tell us who you are.
Yeah, my name is Robert Kutzner. I'm a pain specialist, anesthesia background, intensive care, and I'm also interventional, old guy. So now I'm just got a little pain clinic, and work with multidisciplinary approach. Anyway, my practice, yes, I see the addicts come and go, but there's ways to address that. One is cures, which is a great program, guys. Maybe you run a little bit behind, 1 month, 2 months. Sometime you'll get, take care of that. But specifically, when I am dealing with an addicted patient, somebody that's drug seeking or they have a lot of drugs, I don't deny that they might have pain. Obviously, addicts can have pain too. I take advantage of the opportunity to treat them. I got them now. Okay? And we try to do at that time cures and pain agreements, etc. One of the things I do is old school, been around forever. I'd like someone here to comment on it because I don't see it in practice too much. There's a few people that do it mostly at the university level. But that's a blind pain cocktail. It's very hard to snort up cherry syrup or shoot it up, etc. And it works very well. It's been around since Egyptian times. Would you comment on that, please?
I think blind pain cocktail is a great way to supplement a detox. But one of the things that we learn is that detox and treating an addict is it's not a monodisciplinary field. You need help. You can't do it all on your own, especially those of us of anesthesia background.
Yeah, let me interrupt for just a second because I have a Suboxone license and all that stuff. I don't detox patients. I got a clinic, and I'm treating pain. So it's not a detox issue. It's an issue of controlling diversion.
Well, it's also an issue of opiate reduction. I don't think it's really possible. It's very difficult to assess a patient's pain when they're on large doses of opiates, especially if they're walking in the door on large doses of opiates. You have no idea what their baseline is. And it may be that they're hyperalgesic. It may be that the opiates have accelerated their complaints of pain. And so you really do need to do some kind of opiate reduction. And whether you want to call it detox or opiate reduction really doesn't matter. And a blind pain cocktail is a really good way of doing that if you've got a cooperative pharmacy and a cooperative patient, and you've got the whole thing set up.
Okay, so why, you pharmacists and you physicians, why aren't we turning to that for these minority of cases?
I don't know what that is.
A blind pain cocktail. You come to me and you're taking, 100 milligrams of morphine a day, equivalents of hydrocodone. I give you 60 milligrams in morphine or some narcotic in cherry syrup. You get your little flask. Lasts for 2 weeks. I probably put hydroxyzine in it and acetaminophen, something like that. You agree that you will not know what's in there. If you want to know, just ask me. I'll tell you, or ask the pharmacy, I'll tell you. But then, boom, you're done. If you do that, then I take every 2 weeks and I cut back the narcotics. I have one patient now, I've had many in the past, will end up on cherry syrup. And I end up having to tell them, hey, we're doing good now, you can just get off the stuff.
Okay.
So you're right, it works very good. I'm just flabbergasted that with all the people that are dying and stuff, all these things going on, I know that Dr. Mackey at Stanford does it. I know a lot of people who do it. Why aren't we doing it? Why isn't it being promoted?
Thank you. I'd like to ask the pharmacist, once the determination is made that a patient before you may be addicted, what do you do?
Yeah, so if probably made a contact to their physician to kind of get confirmation on that. I think the idea is really to kind of look out and get some help for them. You probably, if this is a patient that regularly coming to you, you will have a relationship with them. You have that discussion with them that you are concerned with their health. You are looking out for the patient's best good. You may want to refer them back to their physician, maybe refer them to a pain specialist to figure out what's the best option for them. The pharmacist definitely has a responsibility not to fill that prescription for a patient if you really know that they're addicted, because you need to prevent any harm to that patient from happening.
I just wanted to add a little bit about that. I always look at the issue between dependence and addiction, and we have to make sure that the addiction piece of it is that there's the psychosocial behavioral issues, the functional issues, the diversion, and I think that's where the pharmacy has to come in and address that. We have, had patients there, and we go and talk to the patient, because a lot of times it's really difficult to get a hold of the physician, and, ultimately we can say, I'm not going to fill it, but I like to follow the patient-centered model, and I talk to them and tell them, I said, I have concerns about what you're getting, where you're getting them, the doses, and I kind of lay out what my concerns are as a pharmacist, because again, we have this much information. But I do think it needs to be addressed by the pharmacy, and we can tell them at that point that I am not going to fill it, or I need to get a hold of your physician before I can fill this. And, nobody really dies from withdrawal, at least from opioids. And it is uncomfortable, but I will it's not an emergency in my mind. I need to get a lot more information as a pharmacist. But we're definitely at a very limited space there.
At what point should the pharmacist pull a cures report?
Yeah, Dr. Kutzner again. One clarification, one question. Blind pain cocktails are not coup de grace, save the world, but they will help you in Merced or wherever you're at if you got a diversion patient. They are cleared by and governed by the California Code of Regulations. You should be intimately involved with the state pharmaceutical board. They can tell you, where to look it up. Now, going on with my question. We're talking about pain management here, where all these issues and people dying, etc. Anybody here belong to the current MTU or the previous MTUS committee? Please let me know. Raise your hand. Anybody here? Nobody up on the board. All right. The medical treatment utilization schedule is funded by you guys every year or every 5 years to review all the evidence-based medicine out there regarding pain management. Currently, they're doing that right now. There's like 22 gentlemen and ladies like you that are really good at this. And they go through all the evidence and they write down basic treatment guidelines. All right, now, these treatment guidelines are every bit as good as Benika's book on pain management, etc. There's like 500-600 pages. And what I'm asking the committee here is it is, every year, every 5 years, it is a state law. It's a regulation, Title 8, Section 20, Section 9297.2. And it says, us providers shall follow, this MTUS guidelines. We don't, obviously, and nobody seems to enforce it. And look around the room. Nobody even raised their hand saying they know about it. Why? What's up with that? We're spending lots of money, a monumental task, that deserves lots of applause for Dr. Levine and everybody over there who are doing this, but it's not trickling down. The insurance covers, adjusters are denying cases. The providers are jumping through it, and everybody's kind of out doing their own thing. Why is not the MQS being marketed, or why don't we know about it?
Any comments? Thank you.
The medical treatment utilization schedule is a law for guiding the care of pain patients in workman comp. Why is that information? It stops right at the state. They're doing it. It's remarkable. Other states follow it. Why is that information not trickling down to us so that we know and don't have all these questions for you? The citation is Title 8, Section 9792.2 to .26. It's a law. It says it's the authority. It also says providers shall follow, required. And it talks about everything you guys talk about. It talks about everything we know. If you know pain management and you go read it, okay, it'll be kind of boring to you. It's just same old, same old. But for those of us who don't know and we need guidance, the state's providing that. But somehow insurance adjusters and providers that get on NPNs, they don't know it. What's up? Why isn't it getting down?
We have about 2 minutes left, so we'll try to get your questions, final 2 questions.
Good morning. My name's Ken.
And you might be able to catch some of these individuals at our next break. Our next group coming up, if I can have the panelists come forward, please. Our next panel is composed of enforcement, investigation, and prosecution members. Dr. Winder is our panel moderator and will be taking a number of questions from the audience after we have some presentations from our panelists.
Good afternoon. This is a panel on enforcement and its prosecution, not persecution, if there was any question about it. I'd like to start the questioning off by asking people from the pharmacy board, how does the pharmacy board discipline process work?
Hi again, Dr. Kushner, Bob. First of all, I just wanted to say, when I mentally got to the point I realized that you were doing the same purpose that I was doing, that we work together for patient care. That's when I started becoming more and more appreciative of you. Thank God it's been quite a while now, a good 20 years, so hoorah to you. Second of all, I don't know anything about this. I think you realize if I know about it, I'm going to speak on it. But when you do, how do I even begin? The hell hath no fury like an addict scorned. Okay? So I am sure there are addicts, and you're asking us to, as the problem gets worse, to kind of say, hey, no, slow your roll. So you're going to get more complaints about physicians, and then you're going to go look and you're going to find, I don't know, some of them you're going to find that, they're vindicated, they're good, they did a good job. But it also points out the patient. And is there any plans in the future for the medical board or to say, hey, the patient is really screaming out for help. That's why they're making these accusations. I don't know how you'd even do it, but let's go talk to them. Because I think they're probably pretty high on that list. If they've gone that far, they're probably pretty high on that list of finding them in the parking lot in the morning, OD'd. Are we doing anything, or is there any plans?
I guess I'm a little unclear on your question. Are you talking about patients being the ones who
when
complain
when
to the board about a doctor?
You investigate a physician, and you, for a complaint, and you find out that, the physician did nothing wrong, well, and you realize that the complaint was from somebody that is addicted and they were told, no, they can't have any more drugs, okay? Do we just stop it there, or do we somehow, I don't want to say go after the patient, but, say, hey, you've made it really obvious you got real issues here? Or do we just drop it, doctor, you're okay, go away, and then there's that patient out there floating around?
The patient receives the feedback from the investigation if we're unable to make a violation. They do get that. And we do get complaints from patients that the doctor won't give me my drugs. And sometimes it's really quite obvious that the doctor's doing the right thing. But we would take a look to see. Our complaint unit.
I didn't know you guys were doing good work.
I'll give you all a couple seconds.
Isn't this great? It's well.
All righty. Welcome back. We're on the home stretch and now need to examine what we have learned, what are the expectations, what is reality, what we can do in developing operational and legal solutions. Where do we go from here? The panel consists of Dr. Gutierrez, Dr. Levine, Ms. Harold, and myself. Due to scheduling conflicts, Senator Desaignes will not be able to join us. We're disappointed in that, but we will bring back all of the comments that you have to him, so he understands what has been discussed today, and he has been the main author on cures, so we will want to bring that information back to him too. We are asking for your input during this panel. Discussion as part of brainstorming to give us guidance so the boards will understand what direction we should be looking at and moving towards. As a recap, we recognize that there is a growing problem of prescription drug abuse, and there have been many suggestions on how to address this, including continuing this dialogue and interaction, education, examination of enforcement models, revision of guidelines, new and revised or enhanced laws, addressing cures, and addressing unused prescription drugs, and many more. Dr. Levine, I will start with you, and I would like to have you address...
Not now.
Okay. What the board and what you think the legislature might be looking at, and then we'll move to Dr. Gutierrez.
Can I answer some different questions than that?
No, if you don't answer my questions, I'll have to send you home. No, yeah, you may answer whatever question you would like.
So first of all, I want to commend everyone in this room. It's 4 o'clock Friday afternoon. This has been a pretty intense 2 days, and it is extraordinarily heartening to me to see the degree of attention and focus and interest in this topic represented by everyone in this room. And as one of the prior panelists said, it's a reflection that the problems that we're trying to address as medical and pharmacy boards are not coming from the people in this room. And one of the prior slides said healers and dealers, and I think clearly anyone who fits the definition of a healer is working their hardest and trying their best to do the right thing. And I think one of the themes that I heard from many of the speakers today, though I'm putting it in my own words, is please make it easier for us to do the right thing. That as a primary care physician, as a pain specialist, as a psychiatrist struggling with head-butting regulations and concerns about privacy and what is a primary care physician to do when you inherit a new patient who is clearly dependent upon chronic use of opioids. How do you look at that? How do you figure out who to refer them to? Do we have enough pain specialists in the state? Do we have enough people trained in pain management to serve as support for primary care physicians. Are we dealing with, one of my colleagues from UCSF mentioned the fact that we're doing a pretty good job of getting mothers who are addicted to heroin on methadone. But what about those methadone withdrawing babies in the newborn nursery? You know, how aggressively are we weaning these methadone, these women who've been put on methadone and are maintained on a constant dose of methadone during their pregnancy? Now we have methadone withdrawal babies who look just like heroin or crack babies. So there's clearly a lot that needs to be done on the professional side. And as I said, I'm here as president of the medical board, but I'm also a clinician. And it's very hard for me to put aside my clinician hat. And in my role, in my medical group, the thing that we often, that is sort of our North Star is almost everyone wants to do the right thing. What is it that we can do to make it easy to do the right thing? And making that the default, whether it's, trying to influence the manufacturers to not have the 30-tab Vicodin be the default prepackaged size. A dentist wanting to do the right thing, a physician using an electronic health record that has been preset with 30 tabs of Vicodin. Takes 3 extra clicks to actually order 2 or 4 or 6. How do we go about looking at system fixes and system issues? The fact that if you register for cures and you don't write down the caps and lowercase letters and commas and periods, and you don't use the system for 30 days, you have to start all over again. How can we actually get the users, after our colleague, Mr. Small, said, he's going to work on the governor so we get the money. So how do we get end users who use the system and who desperately want what the system has to offer to work with the IT staff to ensure that the system is in fact as user-friendly as possible? So I think there's a lot of things that we've heard, that I've heard, now putting on my medical board hat, around how we need to think about, are we doing everything we can given the information we have? When someone calls the medical board with a complaint, are we sure they're getting the right information about what's going to happen with that complaint? Are we encouraging or discouraging complaints? What else can we do in a proactive way around educating not just clinicians, but members of the public, dentists, who I think in many ways also need to be involved in this conversation? And how do we replicate this audience in the Central Valley, in Southern California, in San Diego, in Redding, so that we can bring this quality information and exposure, not just to those of us who are fortunate enough to be able to access this day? How do we ensure that this is the beginning and not the end of the information and education process? I'm going to turn this over to Dr. Gutierrez, who is going to speak on behalf of both the medical board and pharmacy board on recommendations that she's put together.
Thanks, Dr. Levine. And again, I echo Dr. Levine's remarks. Thank you all for being here today. We've heard all about the issues over the last couple days. We had experts from the DEA. We had people here from the White House. We have had experts in the audience. And I think we just have to talk about now what are going to be the next steps that are here. And we've put together a slide presentation that actually goes over some of them that we've kind of culminated in terms of some ideas. But then we'd like to hear from you. If there's anything we may have missed, if there's any ideas that you believe should be added to that list for consideration, on behalf of the pharmacy board and the medical board, we'd like to hear them so that we can consider those as we start moving forward. One of the big things I'm concerned about is making sure that, at least from the pharmacists, who are the last line of defense, that we've got the information to be able to do our jobs as pharmacists. And I speak not only from the pharmacy board, but as a practitioner. We have to make it hard to do the wrong thing. So you just buy a new car right now, and I tried to take my key out, and boy, these buzzers went off, and it just would not let me I could not lock my door. I couldn't lock my keys in my door. Yet we have such systems, at least even with cures, where it's not very easy sometimes to get the information. When we have EHRs coming up and we have cures in other states, that we don't have interoperability of data. So I think looking for trying to make that cures data, at least to our pharmacies, a lot more easier to utilize so that we can actually do some actionable actions with them. But I'll turn it over to Jenny because she's got a slide presentation on some of the items we believe are action items, and we'd like to hear from you then.
In the room, not only is it just us, Linda Whitney is the executive director of the medical board. And so you have the medical board's president, Sharon Levine, you have Amy Gutierrez, who's a board member, you have myself, and I'm the executive officer of the Board of Pharmacy. Also within the room are a number of board members of our two boards who took 2 days off, much like you, in order to attend here and be part of this. And so we didn't single them out. We didn't deliberately, here they are, go get them. But they are in the room right now. They're watching what's going on, and so they're very engaged. Do I get to advance, or do you? Well, that's an ability question. I don't know. Okay.
Forward, backwards.
Forward. Okay. I'm low tech. Any of you that know me know I have no business near any electrical equipment. Oh, so here's what we're going to talk a little bit about is expectations versus reality, or where do we go from here? So here we go. Today's forum is only focusing on appropriate prescribing and dispensing. It's limited in our focus to physicians and pharmacists only because we didn't know how this was going to come out. And we are siloed in the medical board and the pharmacy board. To all of you, you may think we're together all the time. We're not. We don't work together very much. Over the last year or so, we have joined very closely with the medical board because we have recognized the commonality of interest, because what's good medical practice leads to better pharmacy practice. We want you guys providing optimal care to patients in the state, and I know that's what you want. But as healthcare practitioners and professionals, a lot of this isn't black and white. That's why you went to school for so long. A lot of them are going to be your judgment calls, and sometimes we're going to disagree with each other about what's appropriate. So, why are we convening this forum? You want to hear the whole sordid story? The actual truth was there was a bill introduced in the legislature a few years ago. We probably would have gotten here anyway, I think. But there was a bill introduced in the legislature about 2 years ago that was going to eliminate, as a cause of action for the Board of Pharmacy, clearly excessive dispensing. That is one of the linchpins of the corresponding responsibility we've been talking about. We have court cases that support that and allow it as a disciplinary grounds. And we were alarmed. The sponsor of the bill said there is inadequate, this is 2 years ago, keep in mind, there is inadequate and insufficient pain treatment in California, and we've got to do something about the regulators that are imperiling patient health. As you can see from the numbers, I'm not sure who's imperiling who here, but we were able to get an amendment to take that particular provision out. It was an unintended consequence, they said. They didn't mean to restrict our ability to enforce our law, but the commitment was we will work on a pain forum for our practitioners with the medical board, and the medical board was in the room at the same time. And the commitment was not only made with the author's office, we also had a legislative committee sitting in the room. So that's actually what started it. So we knew this day was coming today, and frankly, I'm very pleased with the success with where it's gone, and it's in part because of your enthusiasm, your questions, and your commitment to take a couple of days off of work and come here. We think this is real important. So one of the outcomes, and I think we beat it into you today, is the need for pharmacists to work more closely with the prescriber. And when that pharmacist calls you and says, I don't know why we're prescribing this drug, or I have concerns, we hope you understand that part of that question relates to the fact that the pharmacist has, for whatever reason, the concern. The pharmacist doesn't have access to the records you've got, but it's an important double check, because it's that pharmacist that stands between the patient, and possible injury. And a lot of times, what patients never know, the reason it sometimes takes so long in that pharmacy for them to get their medication is they're calling to confirm or clarify an ambiguous prescription, and they may have just saved the patient's life, and they won't even tell that that's the case, but it sure angers the patients that are in line. So that's our side of the story. And perhaps one of the foremost reasons we're here today is the Cures program. We know it's in danger. The funding is supposed to run out June 30th, which means a valuable resource for us is potentially being eliminated. And for the Board of Pharmacy, we enforce the requirement that pharmacies submit data into Cures. And for the question earlier today, I was going to run up to and grab a microphone but decided against it. If you believe that a pharmacy is not reporting data to Cures, you need to let us know. Don't just let it go. Let us know, because if they're not reporting patient data, we don't know why. It could be an accident. It could be deliberate. If it's deliberate, we want to correct it. If it's an accident, we want to correct it. So, quickly, the good news is I'm not going to make you go over this slide again. I think almost every other speaker that got up showed this slide. I think we can see very clearly the number of kilograms of opioids sold per 10,000 people. It's increasing. Admissions for opioid addiction, increasing. And opioid-related deaths, increasing. Earlier in the week, there was a research letter published in JAMA. Timing is everything. Those of you who've seen the New York Times today know that they've done an editorial in support of moving hydrocodone to Schedule II, which is very unusual for the New York Times, I understand. Here's the JAMA letter. Fatal drug overdoses increased for the 11th straight year. We had 38,000 people die from drug overdoses. That's outrageous in 2010. That is not okay. 22,000 of those deaths involved prescription drugs, and painkillers were found in 75% of those 22,000 deaths. And when it's linked with benzodiazepines, you've got another problem. Now, part of what we're going to talk about in a couple of minutes is the need for education. And yeah, we need to educate our prescribers, we need to educate our dispensers, we need to educate our public. But the public already has a clue. Not only did we have the Time magazine article that was shown earlier today with that great big ugly fish hook and the fish, with the teeth. People magazine about a month ago, right about the time we were doing the final prep for this meeting, People magazine came out, and it's a little hard to read. Prescription drug abuse in the lower right, a deadly problem. And here's the inside story, the front page, one death every 24 minutes. These are everyday people in People magazine. Now, once in a while, People magazine goes off and wants to highlight a everyday kind of story. But this is not a story about celebrities, which is usually where People magazine goes. This is like, it's out there, folks. So it's pretty widespread. We have a moment, an educational opportunity. The first thing you've got to do in order to educate the public is you've got to get their attention. They're becoming aware of this, I think. One of the other issues we need to deal with is prescriptions aren't just dispensed within California anymore. They go across state lines. We need to make sure that Cures is funded, and once funded, we can access data on patients across state lines. Right now, the National Association of Boards of Pharmacy has a program they call Interconnect, and they think by the end of this year, they'll have 25 states connected. That's half the states with half the U.S. states, and half of them with programs, assuming Missouri finally comes through. But we don't want to be the exit out of the system either, so we're going to have to find a way, and some of you are going to have to be some of the solution to how we fund Cures. We also need an upgrade in our system. When I get pulled over by that cop, by the time the cop gets out of his car, walks up to the front of my car, he knows who I am, what arrest warrants are out for me, how many times I've been in jail, and any number of other things about me, all within the space of a few feet and walking up to that window. You as practitioners, you as pharmacies need to have that same kind of access to prescription information about your patients so that you have online, if not absolute real time, within 3 weeks, if we can get it that fast, that's even good enough. Because for 3 weeks, let them scam the system. They're going to get it on the 4th week anyway, and then they're in the system. But we need to make the system more user-friendly. You saw today how difficult, and it was actually, Mike did a nice job of highlighting some of the enhancements we can put into the system. So we've got a long way to go. We need to go there. The other thing is, again, Schedule 5 drugs. Promethazine with codeine selling for $600 a bottle in Texas that was sold in Los Angeles at $9. I mean, come on, why are we in this room? We can all make some money and just go sell it. If we could get our hands on it, I suppose. We need to track Schedule 5 drugs, especially since once it goes across state lines, a lot of states are tracking Schedule 5 drugs. We need to do it too. And by the way, most of you may know this, but perhaps you don't. There was a change in the cure system about 2 years ago, and we shifted from using California's schedule of controlled drugs to the federal schedule. Hopefully your software programmers recognize the shift, because otherwise you're reporting not all of the data. The federal schedules are kept up to date a little more rapidly than California's. They're mostly the same, but there are a few differences. Now, this is Amy's, but before I hand over the podium to her, I've got a couple quick things. California is the largest state. We are here, and our mandates of these two boards is only consumer protection first and foremost. If we do anything else, that's fine, but our job is consumer protection. So some of the things we do may seem like they're rubbing you the wrong way, and maybe they are. Our goal should always be consumer protection. And if your goal is consumer protection too, hopefully we'll all be going in the same direction. In California, in 2011, I think, it might have been 2010, I don't know what year, it was one of the 2 years, but it was the last year data was available. There were 4 billion prescriptions filled in the U.S. 650 million of those prescriptions were dispensed to California patients. We have far more than 12% of the drugs being dispensed in the U.S. in this state. We have to be the first state to really aggressively take on the various aspects of this for the consumer protection of our public.
Thanks, Jenny. We're going to go over some ideas
on our list. Back of the room, this side.
Again, thank you. I just want to reiterate, I don't think there's a faster way and to touch, what are the 45 million people in California, than implementing through the workman comp, the MTUS. Just ask that providers that are going to be workman comp providers on MPN lists and insurance companies that are going to provide workman comp insurance, just ask them to acknowledge that they will at least read the MTUS. The money you save there in workman comp, I think, should all go to the cure system. And then the other comment is for the pharmacy board, please somebody look into a little bit more blind pain cocktails and using in patients that have addiction or diversion issues. I think it'd help a lot of us out here. Thank you.
Thank you.
The entire forum video can be found on YouTube. In addition, for those of you who are treating pain patients, you can find the MTUS treatment guidelines online at the Division of Workman Comp. So farewell, and thank you for taking your time to promote better patient care.